Getting into patient care, maybe as a paramedic, maybe as a doctor, well, you really need a good handle on CNS stimulants. It's not just optional knowledge.
No, definitely not. These are meds you're absolutely going to encounter.
Exactly. So let's dive in. We want to make this clear because it can feel pretty complex. Welcome to the deep dive.
Yeah, glad to be here.
Today, we're really unpacking CNS stimulants, the pharmacology, how they're used in the clinic. We're using a pretty detailed article as our guide.
That's right. And the goal isn't just memorizing facts. For you, our listeners training or already working in healthcare, it's about understanding how they work and why that matters for your patients.
Right. Our mission today is to pull out that essential knowledge, the mechanisms, the uses, the really important considerations. And there's some practical bits in here that might surprise you.
Absolutely. And what's quite striking is just how many different conditions these drugs can actually help with.
Okay, let's start right there. The uses, what does our source say are the approved applications? It's quite a list.
It really is.
ADHD is, of course, a big one. You've got methylphenidate, amphetamines.
The mainstays, really.
Then there's narcolepsy. That's where modafinil and armodafinil come in.
For excessive daytime sleepiness.
And interestingly, phentermine gets a mention, but just for short-term obesity management.
Yeah, as an adjunct. And modafinil pops up again for fatigue and shift work disorder.
Right. And even some off-label use, like boosting antidepressants sometimes.
That's mentioned too, yeah. It shows the breadth.
It's definitely broader than I might have initially thought.
It is. And it highlights how tweaking neurotransmitter activity can really have wide-ranging therapeutic effects. Understanding that basic principle helps you grasp treatments for so many different patient scenarios you'll face.
So these stimulants, they're not all the same, are they? How do we break them down? Our article classifies them, gives examples, even some common brand names you might see, say, in India.
Exactly. Classification helps make sense of it all. You've got the amphetamine class, think dextroamphetamine, lisdexamphetamine, maybe under brand names like Adentrol or Lisday.
Okay.
Then there's methylphenidate, very common. Names like Inspiral, Ritalin, really key for pediatric ADHD, as you mentioned.
Right.
Then the modafinil armodafinil group, Modalert, Wacklert are common brands there. Caffeine, of course, we all know caffeine. Caffeine, Nescafe, it's technically in there.
Yeah. Good old caffeine.
And then phentermine, often as Duramine, kind of in its own category for that short-term weight management.
And for each of these groups, there are specific things to remember, right?
Yeah.
Little details that matter clinically.
Precisely. So for amphetamines, like lisdexamphetamine, it's a prodrug.
Prodrug, meaning?
Meaning it's inactive when you take it. It has to be metabolized by the body first. This actually gives it a slower onset and potentially a lower risk for abuse compared to immediate release amphetamines. Plus, often a smoother effect through the day.
I see. That makes sense. And methylphenidate.
Key thing there, often first line for kids with ADHD. And you need to know it comes in short acting, maybe 4 to 6 hours, and also extended release versions for longer coverage.
Okay, different options for different needs. And modafinil.
The big points for modafinil are its lower abuse potential compared to the others, and its specific niche for narcolepsy and that really disruptive shift work sleep disorder.
Okay, uses, categories, check. But how do they work? What's happening inside the brain? The nitty-gritty.
Right, the mechanism of action. This is core to understanding why they help. So amphetamines are interesting. They do two things. They boost the release of dopamine and norepinephrine, and they block the reuptake.
So more neurotransmitters getting out and less getting cleaned up.
Exactly. Like turning up the faucet and partly blocking the drain leads to more arousal, better focus, alertness. Methylphenidate, on the other hand, mainly works by inhibiting the reuptake transporters for dopamine and norepinephrine.
So it's more focused on blocking the cleanup crew.
Pretty much. It slows down the removal so those neurotransmitters hang around in the synapse longer, amplifying their signal.
And modafinil. You said its mechanism was a bit different.
Yeah, it's more complex. It does have a weak effect on dopamine reuptake, but the really interesting part is its influence on other systems, the orexin and histamine pathways.
Orexin and histamine, those are linked to wakefulness, right?
Exactly. That's why it's effective for narcolepsy and shift work disorder. It promotes wakefulness through those pathways. And then there's caffeine.
Yes, my morning essential.
Right. So caffeine works mainly by blocking adenosine receptors. Adenosine makes you feel tired, so blocking it reduces fatigue. Plus, it gives a little boost to dopamine and glutamate release, too.
So bringing it back to ADHD, how do these actions, like boosting dopamine or norepinephrine, actually help with the symptoms you'd see in a patient?
Well, think about the core issues in ADHD: difficulty focusing, impulsivity, sometimes hyperactivity. These are often linked to, let's say, suboptimal signaling of dopamine and norepinephrine in key brain areas controlling attention and executive function.
Okay.
So, by enhancing that signaling, these stimulants can help improve focus, reduce that impulsivity, calm the hyperactivity, things you'll be looking for when you assess treatment effectiveness.
Makes sense. Now, the article mentions tolerance or resistance.
Hmm.
What's happening physiologically when a drug seems less effective over time?
Yeah, tolerance. That's when the body adapts and you need more drug for the same effect. A key mechanism is receptor downregulation. Think
Downregulation.
of it like the brain reducing the number of docking stations for the drug or neurotransmitter if they're constantly being overstimulated. It's trying to regain balance. And genetics can play a role too. Variations in genes like DIO1, the dopamine transporter gene, can affect how someone responds or develops tolerance.
Okay, the body adapting. What about how the body handles these drugs? Absorption, breakdown, getting rid of them. Pharmacokinetics.
Super important for practical things like dosing and patient advice. Our source gives a nice summary. Methylphenidate, taken orally, usually kicks in within, say, 30 to 60 minutes,
Yeah.
broken down mainly by liver enzymes called esterases. Then kidneys excrete the metabolites. Lisdexamfetamine, being that prodrug, takes a bit longer, maybe 1 to 2 hours, because it needs conversion first.
Mm-hmm.
Then also mainly kidney excretion.
Yep.
Modafinil, similar onset, 1 to 2 hours, but it's metabolized differently, liver CYP enzymes, mainly CYP3A4. Then kidneys again.
And caffeine, the quick one.
Relatively quick, yeah. 15 to 45 minutes maybe. Metabolized by a different liver enzyme, CYP1A2, and not much leaves unchanged via urine.
Those onset times definitely influence how you tell a patient to take them. And you mentioned different liver enzymes. Sounds like a setup for potential drug interactions.
Absolutely. And that leads nicely into some clinical pearls, things really relevant for you in practice. Modafinil's long half-life, 12 to 15 hours. That's why it's usually just once a day dosing. Better compliance.
Yeah.
And with caffeine, its half-life is around 5 hours, but, and this is important for counseling, it can be longer during pregnancy, or if someone's taking a drug that inhibits that CYP1A2 enzyme. Definitely something to ask about in a medication history.
Good points. Now, given these are powerful substances, there must be downsides, adverse effects you need to watch.
Oh, definitely. Critical to know these. We can group them. Cardiovascularly, think tachycardia, increased heart rate, and hypertension, high blood pressure. That's from boosting norepinephrine, the fight or flight signal.
Okay, heart effects. What about the brain? CNS?
Insomnia is common, anxiety, sometimes tremors. Again, that increased dopamine and norepinephrine activity.
Right.
Appetite suppression and weight loss can happen too, probably linked to effects on the hypothalamus, the brain's hunger control center.
I've heard about that.
And psychiatrically, especially at higher doses, there's a risk of psychosis, likely too much dopamine activity. And very important for pediatric patients on long-term therapy. Monitor for potential growth delay. It might affect the growth hormone axis somehow.
Wow, quite a range. How do you manage these if they pop up in a patient?
Depends on the effect and how bad it is. Regular monitoring of blood pressure, heart rate is standard. For insomnia or anxiety, maybe adjusting the dose or the timing. Don't take it too late in the day.
Makes sense.
If appetite loss is significant, nutritional counseling might be needed. Psychosis usually means stopping the stimulant, maybe using antipsychotics, and like we said, track height and weight carefully in kids.
Okay. Are there times when you just shouldn't use these drugs at all? Contraindication?
Yes, absolutely. There are absolute contraindication situations where it's generally a no-go. Pre-existing serious cardiovascular disease like certain arrhythmias or uncontrolled high blood pressure is one, and crucially using them at the same time as MAOIs, monoamine oxidase inhibitors.
MAOIs. Why is that combo so bad?
Huge risk of hypertensive crisis, a massive, dangerous spike in blood pressure. Both drugs increase norepinephrine levels in different ways, and together it's just too much. Avoid MAOIs concurrently and allow a washout period, usually 14 days after stopping an MAOI before starting a stimulant.
Wow, okay. That's a critical safety point. Any other contraindications? Maybe less absolute.
Yes, relative contraindications. Situations where you need to weigh risks and benefits very carefully. Things like glaucoma, hyperthyroidism, or a history of substance abuse. That last one is obviously a big consideration given the abuse potential of some stimulants.
That MAOI interaction sounds incredibly serious.
It absolutely is. It's one of those interactions you just have to know. Patient safety depends on it.
So beyond MAOIs, any other major drug interactions we should flag for future prescribers?
Yes, a few more key ones. We touched on amphetamines with SSRIs or SNRIs that can increase the risk of serotonin syndrome, too much serotonin activity.
Right.
Stimulants can also make blood pressure medications less effective, so you need to monitor BP closely if a patient is on both.
Yeah.
And here's a huge EE one, especially for exams and practice. Modafinil induces CYP3A4.
Induces, meaning it speeds up that liver enzyme.
Exactly. It makes that enzyme work faster. So other drugs that are broken down by CYP3A4 might get cleared from the body too quickly, reducing their effect.
And a key example.
Oral contraceptives. Modafinil can make birth control pills less effective. That is absolutely vital information for patient counseling.
Definitely. That's a massive clinical pearl. Okay, let's get practical with dosing. Any typical starting points or maximums people should be aware of?
The article gives some general ranges. For methylphenidate, you might start with 5 or 10 milligrams, often morning and noon. Max dose, usually around 60 milligrams per day.
Okay.
Lisdexamfetamine typically starts at 30 milligrams once daily. Therapeutic range, often 30 to 70 milligrams a day. Modafinil, usually 100 or 200 milligrams once daily to start. Max recommended is 400 milligrams. And again, I can't stress this enough for kids. Monitor those growth charts, height, weight, regularly.
Got it. What about overdose? If someone takes way too much, what are the signs and what's the emergency management?
Acute overdose. You're looking for severe agitation, hyperthermia, really high body temperature, dangerous, and potentially seizures.
Okay, sounds serious. What do you do?
The immediate action is supportive care. Benzodiazepines, like lorazepam, are key for managing the agitation and seizures. Cooling measures if they're hyperthermic.
And long-term abuse,
Yeah.
chronic toxicity.
That can lead to different problems, psychosis, like we mentioned, and cardiomyopathy, which is damage to the heart muscle. Management there usually involves tapering the stimulant dose, maybe antipsychotics for the psychosis.
The article also flagged some very serious warnings. Black box warnings.
Yeah.
What are the absolute must-knows there?
Right, black box warnings are the FDA's strongest caution. For amphetamines and methylphenidate, there are two big ones. First, high potential for abuse and dependence. They're Schedule II controlled substances for a reason.
Okay.
Second, a risk of sudden death if used in people with serious underlying heart problems. Very important screening point.
Wow. And for modafinil?
The black box warning is about the risk of severe, potentially life-threatening skin reactions, like Stevens-Johnson syndrome. Rare, but devastating.
Good to know. Any others?
Well, a key precaution for phentermine is that it's not meant for long-term use because of a potential risk of pulmonary hypertension.
Got it. And the article had one more high-yield fact, particularly regarding that substance abuse concern.
Yes, and it's a good alternative to have in your back pocket, atomoxetine. It's a non-stimulant medication also approved for ADHD.
Non-stimulant, so less abuse potential.
Exactly. It doesn't carry the same risks. So it's often preferred for patients with a history of substance abuse or where there's just a significant concern about misuse of stimulants.
This has been incredibly thorough. So to wrap this up and really nail it down for our listeners, especially those future paramedics, doctors, what's the final exam checklist, the absolute key takeaways?
Okay, let's boil it down. Mechanism. Know the difference. Amphetamines boost release and block reuptake. Methylphenidate mainly blocks reuptake.
Check.
Monitoring. You'll be checking BP, heart rate, watching growth in kids, and asking about psychiatric symptoms every time.
Right.
Contraindications. MAOIs and serious heart disease are the big red flags. Just don't combine them.
Got it.
Toxicity. Acute overdose. Think agitation, hyperthermia, seizures. Manage with benzos.
Benzos, yeah.
Interactions. Avoid MAOIs. And remember, modafinil can decrease oral contraceptive effectiveness. Crucial counseling point.
Excellent summary. So as we finish this deep dive, it's crystal clear these CNS stimulants are powerful tools. They offer real benefits, but they demand respect and careful handling, especially from you, the future